And the purpose of the talk is to help us to continue to think of the theory that might guide the research that you're going to be doing, as well as different methods for really getting at the issues with the populations that you're working with. So why do we do ethics? We do ethics because research is a moral endeavor. At least that's how it feels to me. And I think the way that people have been talking about it, I think it's something in us that we may not always articulate, but we're trying to do good. We want to protect the autonomy and welfare of our participants at the same time and ensure that they have equal access to the benefits and burdens of our science. But when we're working with the marginalized groups that we work with, it poses ethical challenges that really jeopardize these kind of obligations that we'd like to fulfill. So it's important to think about, as I said before, that good ethics is good science, right? We do all these things in terms of we protect confidentiality, we get informed consent, we try to have fair inclusion, exclusion criteria. I'm not sure we always succeed. And we try to minimize risks and maximize benefits. And that really leads to better recruitment and sampling. It leads to participation and retention of those that we're working with. It also improves, as you'll see in some of the studies later that I'm going to talk about, response accuracy and honesty and external validity and impact. So when we're doing good ethics, we're getting much better science. But our intentions are not enough. Speaking to each other, speaking to IRB, speaking to the government is not enough, because members of these groups that we're working with can view research benefits and harms and the social values very differently than the research establishment, as well-meaning as maybe we are. So from a goodness of fit ethics, which is a theory I've developed over the years, fitting ethical procedures to the values and concerns of participants cannot solely rely on our experiences and our own moral reflections. So what's needed and why this institute is here and why you're going to be doing your research is an empirical basis for research ethics policies and practices that reflect participant values and their lived experiences. So from a goodness of fit ethics perspective, investigators and participants are equals in terms of their expertise, but equal but different. So as you know, we have all this knowledge about scientific knowledge base when we're doing a study. We know how to test hypotheses. We know how to choose measures and methods and do data analysis, and we know the federal regulations, but our participants understand their health priorities and their cultural values. They also understand better than us the barriers that are going to occur to recruitment and retention and why. They understand the real world context in which we're going to be testing our hypotheses, and they reflect very differently on what the social value and impact is. But I think what's always important to remember is that the participants, just as us, have the ability and willingness to grapple with some of the ethical challenges. And a lot of my research, at least, has been looking at people who use drugs and people who are living with or at risk for HIV as moral agents. And I think we forget that they are moral agents. Okay, so when we're doing the kind of research, when you're doing your MRP, you really want to avoid getting cookie cutter responses from people. So just as we don't expect our fellow scientists to provide uninformed, non-deliberative and kind of categorical answers like yes, no to ethical questions. When you design your MRPs, you want to encourage informed contemplation and diverse participant perspectives on the research ethics issues that you're interested in. So from a goodness of fit study design, how do we draw on participant expertise? Well, first, our aims have to be to understand how participants evaluate risk and benefits, social values, scientific validity, the research goals and procedures, depending upon what you're studying. the materials that we provide have to be explicit descriptions of the research methods and context. If they don't really understand the research, they're not going to be able to give you any perspective on the ethical issues. And you can do that, as I'll give examples of, through videos, animations, written vignettes, talking to them. When the data is collected, you want to include, whether you're doing surveys or you're doing interviews or focus groups, questions that explicitly communicate and clearly address the ethical and methodological issues that are the focus of the inquiry. It shouldn't be a secret that we're interested in the ethical issues. It shouldn't be a secret that we struggle with ethical dilemmas. And then the procedures, as I said, should encourage that they think about things, and it's not a simple agree or disagree with some kind of question. So the first study I'm going to talk about, actually, my co-PI was Merrill Singer, and he really, I think this was my first endeavor in terms of HIV risk and drug abuse in terms of ethics. So this particular study was a multiple year grant, but these were barriers and opportunities for recruitment for non-intervention studies on HIV risk. And you can see from the date, it was, quite a while ago. And so you'll see that at that time, there wasn't rapid HIV testing, but you'll just see from the video that there were some things that were not available yet. So once again, I want you to be thinking about your own MRPs. That's why I'm doing this, right? So what's the general aim? How can participant perspectives contribute to goodness of fit recruitment procedures, right? So this is on a recruitment question. So here are the specific key questions. Do you want to think about what are your specific key questions? How do concerns regarding privacy and trust influence PWD reactions to street recruitment practices? What are the perceived personal and social risks and benefits of participating in non-intervention drug use research that includes HIV testing? And remember, this is non-intervention research. And are monetary incentives for people who use drugs, participation in this kind of research, do they view it as harmful, fair, or coercive? So once again, when you do your research, you really have to know what the ethical issues are in the field so that your research questions can address that. And so we can communicate that to scientists, IRBs, and the NIH. And I'll show you how this. So in this study, we had videos of ethics vignettes that had actually been occurring. And actually, Merrill Singer had written a book about some of the ethical issues that they were confronting in drug use and HIV research. We developed these vignettes, and before we filmed them, we had a cab that was PWDs as participants to help us with the language so that it was real language and not our language, so that was really helpful. We had all of the videos in Spanish and in English. We kept, sometimes it was a male researcher, sometimes a female researcher. So, we kept changing the genders. We ran 11 focus groups with 100 economically, educationally marginalized PWDs who are ethnically diverse, and 39% had HIV. And it was great because we partnered with Housing Works. And so it was really terrific. Okay, so here's what we told them. We've issued here today, get your advice on how to improve the way research is conducted when it involves persons who use drugs and are at risk for HIV. And you'll see that the narrator in this video I'm going to show you encourages focus group members to think about case-specific ethical issues. And I want you to know, especially with the focus groups that they ran, they were talking back to the video. I mean, they were, we did a good job because they were really talking back to the video. And we had no trouble getting actors because we live in New York. And we put out ads. We had 100 people want to be in these things. Some of them were good actors, some of them weren't. But anyhow, this is one of the videos. Okay. So you see, they were primed about ethical issues to look at this from an ethical perspective. Okay, so we showed them the video, and so these are the questions that we asked them. Okay, and I want you to see how these questions, they really are addressing our issues, but they're not in our language, and that's what's really important. Okay, so what did you think about how John approached Sarah? Do you think Sarah was told enough about the study to agree to make an appointment to participate? What do you think about the fact that she won't be able to participate if she comes to the center too high? Okay, so these are issues we all face when we're working with this population. We asked them about research risks and benefits. If you would say, Sarah, would you agree to be in the study? Why and why not? And for those of you, if you've done qualitative studies before or did surveys, do not ask yes, no questions, because all they say is yes and no. So always ask why or why not. Okay. What do you see as the risks to Sarah if she agrees to be in the study? Are there ways to reduce those risks? And are there benefits to Sarah, the community, and other drug users? Then we asked about monetary compensation. Do you think $40 is fair payment? So do you think the offer of $40 would be so much that the participant couldn't turn it down even if she didn't want to be in the study? I'm reading this slowly because this is almost exactly the language that Zeke Emanuel uses to define whether or not something, monetary compensation, is coercive or not. But I'm not using highfalutin language to get at that ethical issue and what their perspectives are. And, what if research offered her $100? Okay, because it's interesting to see whether or not they say, oh, yeah. And by the way, the participants did not. They said that was too much when we spoke to them, that the 100 would do. They would just say yes, no matter what. What year was that? Yeah, that was a long time ago. Okay, yeah, $40 was actually a lot of money at the time. So, Yeah, ignore the amounts. And what if Sarah was offered coupons for food or clothing? That's another big ethical issue that Brandon Brown will talk about, right? Because all they do is sell their coupons and they get less money for them. And so it's really not fair. But the IRBs always say coupons, coupons, coupons. Don't give them cash. So then I asked, do you think researchers should give money to persons who use drugs, who may use the money to purchase drugs, right? Because that's the ethical question from the IRBs. That's so annoying. All right. So what did they tell us? Once again, this was very, inductive kinds of stuff, obviously qualitative. So they were concerned, why are you doing this in the park? The police are there, they're always undercover. The public exposure, somebody next to me could know that I'm now, I'm a drug user, or that I'm coming to be tested for HIV. That's a, big issue. But at the same time, and those of you who have done recruitment of people who use drugs or who are marginalized, if they feel that the researcher is honest and if they're respectful, they're very likely to participate. And there are some recruiters been around for years and oh, Becky, if Becky is doing it, then, that's going to be good because I trust her. And you can see respect is so important that you're not trying to downgrade these people that you're talking to. Another issue is something called inflicted insight. I don't know if you're familiar with that term, but that's really when somebody learns in research something they really didn't want to know about themselves. And, so for these people, and of course, this was a while ago, so they were very afraid of finding out if they had HIV, right? Because that was very scary, and we'll talk about other things, and the stigma that's associated. But at the same time, they felt this is important because it's helping me with my personal responsibility, and it might help me get off the streets. Okay, and I think I'll mention it later, but it doesn't know. Some of them have been in jail and they felt jail saved their life because for the first time they were tested for HIV. So they were also very pragmatic about money, right? As we know, nobody's going to do it with half the money, especially in non-intervention studies, that it's a benefit because they wouldn't find out if they were sick at the time, as I said. They're very annoyed about the paternalism, right? That, this whole notion of should you pay drug users money if they're going to use it for drugs? And many of them says, I'm a drug user. Do you really think I'm not going to use drugs if you don't give me money? It's just, that's what I do. So I thought that was important to communicate to IRBs. And of course, they sell the coupons, and we know that that's unjust. At the same time, they were concerned about who's being approached, and if the person was, really high, then it could be exploitive too. Just mention money, and that person would say yes to everything. So I think what's important, and we see, you shouldn't expect everybody answering the same. Just like we will disagree on ethical issues, that it needs to be very nuanced, and you have to present in your articles both sides of the issue. That we need to address. And so if you're going to write an article, what's the take home? Obviously avoid alerting law enforcement, take steps to avoid HIV and drug use community and self-stigma, which I'll talk about a little more. Develop respectful approach methods that engender trust. Be honest about the potential exclusion from participation, because sometimes we don't do that when we're doing research. Be sensitive to their HIV testing fears, and use recruitment as an educative opportunity about HIV treatments, right? The kinds of things that he was saying was informative about HIV testing. And we can see that. And in terms of monetary incentives, I won't go into it all, but, obviously avoid coercion if they're in withdrawal or having cravings or high. Obtain community input on what is non-excessive. I'm sure you all do that, but we always, the CAB is very helpful in terms of what is the amount, and you can take that to the IRB. The issue of coupons, and the fact that we should respect that they can spend their money just like anybody else can. who's not a drug user. Okay, so here's the next study was on assessing and enhancing HIV vaccine trial consent preparedness among street drug users. When was this study? It was a long time ago, and we still don't have a vaccine, but at that time, it looked like it was right down the road. So unfortunately, we still don't have one. So what are the research questions? What are informational barriers to HIV vaccine trial consent among marginalized persons who use street drugs? So we looked at two things in terms of barriers. Do they have knowledge about HIV transmission, about vaccines themselves, and about research? And then what are the issues involved in research and medical distrust? This was actually a survey study. So we were actually asking questions, and we had a pre-test and a post-test and a brief lesson in the middle. And when we piloted in the beginning to determine what they didn't understand and what their informational needs were, and of course we met with the CAB about that. We did street recruitment. We used community storefronts. A lot of these people, had less than a high school degree, so everything was read to the participants, and we had 30 participants there. Okay, I'm not going to go through everything, but this was an incredibly effective PowerPoint on a tablet, sitting down, reading to these individuals. And in fact, when we were finished, many times they would thank the research team member who was doing this for giving them information, because they were getting information about HIV as well as other things, and nobody ever talked to them. So that was nice. So, we want to give our science away. That's one of the things we want to do. So I think what's important here is this is very pretty. It's very clear. It's not in any kind of highfalutin language, but it's really honest. Okay. So for example, researchers do not know if the vaccine works until the study is over, right? Very, very important to emphasize that. That there is no vaccine for HIV right now, right? Because we don't want a therapeutic misconception that half the people are going to get the vaccine, half are going to get placebo, because that's the only way researchers can know if it works, right? So telling them that. Randomization, explaining what that is, what the side effects are going to be. Now, we adopted this from the current vaccine studies that were going on. So that's at the time, what was the risk, et cetera. Only people who are HIV negative can participate, right? So we're telling them what the inclusion exclusion criteria is, and that they would have to get an HIV test, what they can expect, because these studies go on for years. You have to keep visiting, how much you would be paid, the fact that you'd have to have blood tests. How will the researchers know if the vaccine works? They would do blood tests, then they would compare the two groups, the placebo and the HIV group. The vaccine does not contain the HIV virus. It's amazing to me how these issues are the same thing with COVID. That is what people do not understand and what they're afraid of. Because remember, we piloted this to see, I don't want to get HIV when you give me the vaccine, right? That you cannot get HIV from the vaccine, and you can't transmit it, because a lot of them were afraid that it would be in their system. We talked about false positive tests, confidentiality. Okay, so what did we find? When we did the post-test, we found that, wow, the knowledge really increased. They understood more about, randomization. They understood more about the placebos, about that the vaccine does not contain the HIV virus, et cetera, et cetera. So we really were able to reduce the misconceptions that they had. However, you can see we were really less successful in reducing mistrust. That takes generations, not just, sitting there with somebody. And I think this notion of guinea pigs, you probably all heard, right? Many times. So what's the take home if you're writing an article, which of course we did? And so take homes that you would have. So without educational lessons, this population may be unprepared for valid informed consent. That these pre-study lessons fitted to the participants' informational needs, not just what we think they need, but what they actually need, but what we know they are confused about, can improve the informed consent. That enhanced understanding is not the same as believing in the honesty and good intentions of the investigators. This dishonesty is, linked to histories of health disparities and research exploitation, and it leads to our low participation rates. And as you were talking about, I think somebody was mentioning who is in the study, right? Who are in our studies? And then investigators obviously need to work with community groups to develop relationships that would engender trust. And I think a lot of you mentioned the problems with that. Okay, so this is the last study I'll talk about because it's a different method. It's a vignette method that's read to people in an interview format. The other one was a focus group. This is on addiction research ethics. What I wanted to do was I wanted to see, we talk about the Belmont principles, right? You're all familiar with, beneficence, non-maleficence, autonomy or respect, and justice. And the question is, we all talk about it, but does it have anything to do with how our participants perceive the moral values that should be part of research? So what we did was we developed several vignettes. So this was the procedure or the aims. Do the Belmont principles reflect how people who use drugs view the moral world of research? We interviewed 90 economically and educationally marginalized PWDs. We had 3 case vignettes that described actual ethical dilemmas that researchers go to. We read it to the participants. Now, this was a mixed method design. So we had a Likert type scale that I'll show you, and then we had open-ended questions to get at both. So the first scenario is about Dr. Jones, who conducts, she's an ethnographer. She's been for around a year conducting these interviews on problems faced by poor female drug users, raising young children. And she's been sharing her own parenting stories with participants. So just prior to an anticipated police raid, Terry, a female participant, asked Dr. Jones to hide her drugs for fear her child would be taken away. Okay, so this is really addressing the issue of boundaries that I think a lot of ethnographers face, or they say that they face when they're in the community. So Dr. Jones does not know whether or not she should break the law and hide the drugs for Terry. So what do you think, drug users? So then we ask them, in this situation, how important is it for Dr. Jones to obey the law? So what do you think their reactions were?
Signed us this one to read.
Yeah.
Oh,
Resolved.
All right.
It's first
It was going to be read, and you read it, and I love you all. That's fantastic. See, Brenda, you were right. So signing this, and okay. Yay. Okay. So you do know that the first thing is, so then we had a Likert type question, which, how important is it, right? A scale of not important at all to very important. And that was good because it allowed me to, I'm not going to talk about it, but just to statistically compare the values they were doing across the 3 the vignettes. So that was helpful to have that little Likert type scale. And I recommend it a lot of times for when you're doing this kind of research. And then obviously open-ended question. Oh, and so the Likert type question was not a yes, no. It was important, not important, right? Okay, so the major themes were beneficence and respect. Terry could lose her kid, so Mary has to help her. Terry was concerned about her kid. But then what's not in the Belmont report is relationality, right? You got to help the person that's helping her get the data for her research. We forget about the reciprocity. They're giving us something. What are we giving back to them, right? And then professional obligations. This was a big surprise to me. I had to go over this data over and over. I had different people, coding with me because I couldn't figure out what these sentences meant. And then it finally occurred that it was professional obligations, So Dr. Jones should set an example for Terry, not the other way around. And what I learned from this, and it comes up again, as you've read, but what I learned was they don't want us around if we're just like them, because we say we're a researcher and they've agreed to tell us their stories or participate because they think we can do something important with their data. If we're just like them, then we can't do something important with their data. So they want us to keep our professional obligations because it makes what they're giving us more important, because we are going to use it in a way that's going to be helpful in the future, hopefully. Okay, this is the other one that you read about the HIV. This is a big issue when you know that one person you're engaged with both people. Adrian, this may be something that comes up for you, but in a different way, right? That what is the responsibility of the researcher to tell the HIV negative person that they're at risk? So we asked them, and you can see that we in asking the question, we just didn't ask them, should you help? Should you tell Chris? But reminding them that there was an informed consent that promised confidentiality. So we're asking them about the tension, right, between doing good and privacy. And once again, it's not worded in that way. We're not asking them in that language. So Dr. Alba does not know whether he should tell, so we asked their opinions. And as you now know, some of them felt that Dr. Alba's community, I thought this was really interesting because this is what we grapple with, right? With disclosure. Is disclosure of something that we've learned about a participant more important than privacy? And that's the thing, when our ethical issues are in conflict, that's what makes it a dilemma. It's easy when they're not in conflict. At the same time, John has his right to privacy. So that's, respect. But the other kind of respect that was coming up in this and some other research we did is respect for themselves, that they are autonomous human beings. And I think we forget that. So they were saying, if Chris had some sense, he would have done some homework himself. It is not Dr. Alba's job. And I think that's really important, that we're not as paternalistic as we think we are. Relationality came up again. John trusted him with something personal, so he should not let him down. So that's different from an informed consent contract, right? That's about a personal relationship. And again, the professional obligation came up. Dr. Alba should not get involved. Informing Chris is not his responsibility. And then the last one, is, there's a cocaine trial going on, and one of the research assistants who volunteers at a clinic for a homeless person decides that she's going to give all of the people, rather than random assignment, she's going to give all the people in her group the medication. And so I was surprised at this because I thought that, they were going to say you should, she did the right thing because they're very needy. But we asked whether or not Dr. Ross should fire her. So I think that was, because that's his dilemma. Okay, so basically you saw the themes of beneficence, right? Dr. Ross should make an exception because Mary isn't just breaking the rules, she's trying to help those people. But then, once again, they have a sense of science, right? Because it would violate the integrity of the study and it's unproven. So what good is it if you bias everything? We won't know if this can help us in the future. They talked about justice, but not justice from, Mary should help those people because they have a lot of health disparities. But when you make exceptions like that, you are not giving everyone an equal chance. So they're thinking about themselves, right? They might be the people that don't get it. And randomization was considered something fair to them. And I think that's really interesting. We may not we probably think they all want it when we're doing some kind of a research study, and they may want it, but they also understand issues of fairness. And also they were concerned that if he didn't fire Mary, that everybody else would start, defying the rules. And again, professional obligations, if she gets away with it next time, another one of his staff will do it. Okay, so what are the take homes in an article that you read? Importantly, people who use drugs have the ability and willingness to grapple with complex dimensions of morality. I think it's so important to keep telling IRBs and other scientists that these are moral people. That they share with us an appreciation for foundational moral principles guiding research. Sometimes they're high and that's not articulated, but that doesn't mean that they don't care about their families and they don't care about their communities and they don't care about what's right and wrong. And so these, we should not only include the Belmont principles, but also look at these issues of professional obligation and relationality. And they also see themselves as responsible for their consequences. They want us to uphold professional standards, to act as role models, and to avoid the blurring of roles. So when we're conducting ethnographic or other types of research, as you can see, it's important to clarify, and I don't think we do this enough, especially when we're doing HIV or drug abuse, to clarify our role versus a personal role, what we are not, right? Clarify the boundaries in the beginning. And this is especially important if you're doing research in hospitals or in clinic settings, to really say, who am I? Who are the people that are going to do the HIV testing? Who are the people, if it's a clinical trial, who are going to do the research? I mean, who are going to do the treatment? How is this all related? Who has what relationship? Revisit these expectations during the course of the research, especially if you're doing longitudinal research, because those things get blurry. I did a study on adolescent cancer research with parents and adolescents, and half of them did not know they had been in a research study. Even though, believe me, the informed consent was there. They knew they were in a research study when they got into that study, but their relationships with the doctors were so wonderful because pediatric cancer researchers and doctors are amazing. But so they just didn't remember, because it didn't feel that way.
I mean,
Yes.
same thing happened to me. I think I should know that I had signed up for a research study with a clinical trial for cancer. And I mean, I don't even remember signing a consent. Like, I know I did, but just so much was going on and the relationship, and I was like, oh my God, like, how did this happen to me? In a good way, but still just like completely blurred.
And
Like,
who's who? Like who's the researcher? Who's the investigator?
yeah, it's like, we're gonna keep your genetics and we're gonna do this, blah, blah. And I'm like, okay, this sounds great. I didn't even have my glasses on. I have no clue I was in a consent form. I just signed where they pointed.
My grandmother was in an assisted, it wasn't assisted. It was like, I don't even know what it was at that time. It was a hospital. Yeah. And there was a strike going on. And so they were going to take the patients out of the hospital. My grandmother was very worried about that because she didn't want to leave. And a gerontology PhD student asked her to be in a study, right? And so he gives her the informed consent and blah, 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 blah. And then he's trying to test her cognitive abilities, right? And she was pretty sharp, and he's saying, cite the alphabet. She says backwards or forwards, into that. But during the course of it, all of a sudden he said, became clear to her that this was research and that he wasn't testing her about whether or not she'd stay in the hospital. And all of a sudden, and she just turned around. She was in a wheelchair. She just turned around and left him. But the issue was she spent half her time thinking that this was the test about whether or not I'd stay here, even though he did the right informed consent, but it wasn't right for her. And that's the issue, that it has to be tailored to the people that you're talking about. So how do we do good? Well, MRPs, let the participants know that you consider them experts in how they and those who share their life experiences evaluate and react to research our research goals and procedures, that their opinions will help you and others develop studies that reflect their values and merit their trust, that you participants provide friendly explanations about the research methods, right, and content for which their opinions are sought. Get help doing that from the actual prospective participants. Your questions should explicitly communicate what you want to know. It's not a secret. And avoid procedures that discourage these non-contemplative responses.